We can get started here. Just want to welcome everybody back to our spring series of the Resident Research Symposium. This is our final installment. We have another great lineup of speakers that will be telling you about their work today. And we are going to start off actually with Julian Clark. Dr. Clark, like many apparently these days, has drinking the vascular Kool-Aid. We won't hold it against him, and will be telling us about some of his work. So Julian, take it away.
Thank you. Yeah, I'll get right into it, just in the essence of time. So I'm going to present some work that I have been working on towards what will eventually be work for my research here. But the title is Role of Pericytes in Microvascular Changes After Aneurysmal Subarachnoid Hemorrhage. And so just to kind of set the stage about what we're talking about. So primary drivers of poor outcome after subarachnoid hemorrhage is obviously there's initial aneurysm rupture, and that can be split really into the initial brain injury, which is the SAH, and as well as global ischemia, and secondary brain injury. Within the secondary brain injury timeline, first comes early brain injury, which is usually around day 1 to 3 after SAH, and that constitutes a number of things, including blood-brain barrier breakdown, cerebral edema, neuroinflammation, neuronal cell death, and delayed cerebral ischemia, which primarily is large artery vasospasm, but other things, especially in the last decade and a half, have been discovered, including microvascular thrombi, autoregulatory dysfunction, cortical spreading depression, other things like functional connectivity deficits, etc. So my work is focusing on further understanding the relationship of microvascular thrombi in the context of delayed cerebral ischemia. Quick precursor for microvascular thrombus formation. This occurs in after experimental subarachnoid hemorrhage in multiple animal models, multiple induction techniques at a similar time frame to other elements of DCI, including large artery vasospasm. And this has also been confirmed in human autopsy studies of subarachnoid hemorrhage as well. They are independently associated with neurologic deficits after subarachnoid hemorrhage in multiple animal models outside of vasospasm. And so this body of evidence overall is in favor of further investigation into the mechanism behind why these microclots are forming in the microvasculature and how to visualize them, which is where my work comes in. So two specific aims for the project. One is to test the working hypothesis that relaxation of pericytes. So I'll get into a little bit. These pericytes are cells that wrap around the smooth muscle and capillary networks in the microvasculature and contract and relax in a rho kinase and calcium-dependent fashion. I want to test whether the relaxation can be induced pharmacologically using delivery methods that are translatable to humans. And then secondarily, also establish a mouse model for in vivo assessment of pericyte injury after aneurysm rupture. And so this is what I think is happening, and this is what I want to test out. So pericytes are these cells that kind of surround vascular endothelium and constrict in response to various stimuli. After subarachnoid hemorrhage injury, it is known that there's an element of global cerebral ischemia and also blood-brain barrier breakdown. The global cerebral ischemia, there's a lot of evidence in the literature with pericytes, mostly in the context of stroke, that pericytes constrict in response to ischemia. Up to 89% of pericytes will remain alive after ischemic damage, but will constrict. And then a small percentage of pericytes will die with ischemia as well. And then blood-brain barrier breakdown. Pericytes are also involved in this complex network of maintaining the blood-brain barrier. And as the blood-brain barrier breakdown occurs with early brain injury, there are multiple factors that are released that contribute to decoupling of pericytes from their endothelial cell, which also contributes to further what I think is going on. And so all of this to say, pericyte constriction and death is where my first aim is focused. With pericyte constriction and death, what I think is happening is that given the fact that they are constricting around capillaries and causing a subsequent decreased microcirculatory blood flow, I think that's something that contributes to the formation of microvascular thrombi. In addition, the reduction of the blood-brain barrier integrity releases matrix metalloproteinases and other factors that contribute to decoupling the parasites from the surrounding endothelial cells, meaning that they can constrict and then be decoupled and then subsequently are not there to relax the cell. Additionally, that same pathway with blood-brain barrier breakdown has been shown to increase platelet aggregation, and that is a precursor to thrombus formation. So that is what I think is happening and why I want to further assess the parasite relationship to microvascular thrombi after subarachnoid hemorrhage. So how we're going to do this? We have designed a mouse model in Dr. Shi's lab that allows us to drive parasite contraction. How we do this is using these dread mice, which I won't get into too much of the weeds here, but essentially these mice can be induced, a parasite contraction can be induced in these mice, and it can actually be visualized in real time via 2-photon microscopy to see the parasites constrict around a capillary network and contract the entire microvascular system. From there, we want to be able to assess whether we can relax this system pharmacologically. This diagram over here shows that this is myosin light chain kinase is calcium driven and will contract parasites. Rho kinase enzyme is actually the opposite, and Rho kinase inhibits myosin light chain phosphatase, which then contributes to vasoconstriction and net shortening of actin fibers and causes cellular contraction. So the focus for the pharmacologic method we're going to use to try to relax parasites is this medication called Fasudil, which is used in aneurysmal subarachnoid hemorrhage in mostly China and Japan, and is a Rho kinase inhibitor. And the reason for the use of Fasudil is that because of the inhibition of Rho kinase, it acts as a vasodilator. It does also increase endothelial nitric oxide synthase and is already used in subarachnoid hemorrhage patients, just not in the United States. The idea being that if we can try to constitutively contract these parasites that are specific to the central nervous system and then administer Fasudil via multiple delivery methods that we're going to try intraperitoneal and then also intraventricular eventually, to see what kind of response we get to the constriction of parasites. So that is one step in the process. And then the second step is how does this make sense in the context of microvascular thrombus? And so we'll look, the second step is to design a model that allows us to visualize this in an animal. Most of the mouse models of aneurysmal subarachnoid hemorrhage are very effective in causing subarachnoid hemorrhage, but they're very challenging to control the degree of impairment that you get in animal survival, whether it's endovascular perforation model, which is single or double perforation, or the multiple intracisternal injection models with variations in blood volume and location. These models are you can have a group of 10 mice where 9 of them survive, and you can have a group of 10 mice where 4 of them survive. In addition, the level of blood product makes it hard to visualize the microvasculature through a cranial window. And so I propose that we're going to use our 2-photon microscopy imaging system and induce a focal vessel injury via laser in real time under imaging, which causes release of blood product into the subarachnoid space without a lot of the blood product that impairs the ability to visualize the microvasculature in that space. After this, we will able to use the same imaging system to evaluate the effects on parasite contractile state before and during the delayed cerebral ischemia window in an animal model. The idea being that this reduces the morbidity and mortality in comparison to the existing subarachnoid hemorrhage models and allows for real-time resolution, high-resolution imaging of capillary function. And so combining the two, the goal is to eventually put this together into a study of parasite contraction after aneurysmal subarachnoid hemorrhage and see if there is a reduction in microvascular thrombus with the administration of Fasudil. I think that's just about time. So I'll take questions.
Great work, Julian. That's fantastic. Opening it up, questions from the floor.
Hey, Julian, nice work. I'll step in just to get things started. So, can you, I know we've talked about this before, but um, where does this fit in with the general understanding of the elusiveness that is vasospasm? Like, how does studying pericytes answer an existing or open question in the pathophysiology of this disease?
So it's a good question. I'm thinking more about parasites outside of the context of vasospasm. I think that there is a contribution. Parasites are very strongly tied to endothelin 1, and there have been multiple trials with medications over late 2000s, early 2010s, with endothelin 1 antagonists that actually prevented against vasospasm, but did not improve neurologic outcome. And so that's kind of where this thought came from, which is that there's more going on than vasospasm. If you can radiographically, angiographically prevent against spasm and still have no change in neurologic outcome, then there's more happening in the context of delayed cerebral ischemia. I think that there is some contribution from parasites there as well, but given the fact that there's those studies have been done and the endothelin 1 antagonists, while they can prevent against spasm, don't improve outcome, that's kind of where I think there's more to look at from a what else is happening standpoint.
And I see Dr. Murad has his hand up.
Yes,
Pierre.
good morning. Very briefly, parasites play a role in the lymphatic pathway, clearing metabolites. Something else to consider in the context of vasospasm and other neurological diseases.
Indeed, yeah, and that's something that I'm thankful for Dr. Shi for, because he has a lot more knowledge on that and kind of studies that as well. So he and I are talking about how to bring that into the fold, if that is going to be scope of the project, this project, or something that we're going to lean into for future. But that is absolutely correct.
And then Julian, let me ask you, so perfect world, you just have the vessel. This might, it absolutely will help you get down to kind of interrogating mechanism. What happens in your mind when that vessel is diseased and maybe there's plaque on the inside? And so just the properties of the vessel and that constriction are now kind of almost competing against things that might be more, structurally sound in a way that the vessel, couldn't as much respond to, but there's a lot of people with diseased vessels out there. And so how does something like that play a role in this kind of overall effect that you're describing with parasites?
Yeah, it's tough. I would say that the proposed idea behind this model is that the model is very, very, very clean and allows us to look specifically at a cell type and that cell type's response. Overall, in the context of delayed cerebral ischemia, it's a multifactorial process, and there's so many other things that contribute, like the level of how healthy somebody's vessel is at the beginning of all this. I'm not going to be able to study that in this project, and I think that's something that just make very clear is like this is just an attempt to understand a very specific part of this pathway and see if this is something that is intervenable or an intervenable area for improvement in outcome. It's not going to be the be all and end all of the care that we're providing for DCI patients in the future. And that is a question that I'm not going to be able to answer with that, is what happens when somebody has a diseased vessel and how does that relate to spasm, etc. So I'm not gonna be able to answer that. This is just one piece of the puzzle, but we have an opportunity to hopefully very cleanly interrogate it and get some answers. And so that's what I'm looking to do.
No problem. More of on the horizon. And maybe this isn't even your second R01, but maybe it's your third R01.
Who knows?
Very good. Okay. Well, with the interest of time, I think we should move on. So up next is Zach Abekasis, and Dr. Abekasis is going to keep us within the vascular realm, but tell us more about the computational side of the fence in working in the Levitt and Sands lab.
All right, wonderful. Can everyone see my screen? So you see it, Dr. McDonald? All
yes.
Right. I'm Zach Abekasis. I'm one of the fourth-year residents. I will be starting my research here in June. And have been working with Dr. Levitt in his lab to get a better understanding of some of the work they've been doing. So I'll just cover the basics of what I see my project and some of the specific aims that I've been working on with Dr. Levitt and with Sharon Durfee to go through and better understand a very difficult sequela of aneurysmal subarachnoid hemorrhage. So let's see if I can get this to work. Okay, perfect. So the background similar to Julian's project, I'm going to be talking about aneurysmal subarachnoid hemorrhage. And within aneurysmal subarachnoid hemorrhage, cerebral vasospasm is one of the main issues that we run into. Mainly between days 3 to 14, patients are at a significantly higher risk of having constriction of their cerebral vessels that can lead to stroke. We have a few ways that we try to predict this and to prevent this from becoming full ischemic events. One is we do daily transcranial Dopplers, where we look at the velocity of various particles going through the main vessels within this the circle of Willis. Second, we get a CTA to look at the diameter of the vessels, especially in patients that we're concerned about. This, along with the neurologic exam, is a good way to catch vasospasm. And then typically patients that go into vasospasm would go to the angio suite. They would have either intraarterial milrinone injected, or they would have an angioplasty to try to reopen that vessel and allow the blood to recirculate to that area and avoid a stroke. The issue is there are patients that it's really tough to get an exam on because they're intubated or because they are, critically ill. And I think that every resident that's been a junior resident at Harborview has run into the situation where they have a patient where they can get a great exam overnight, get a CT in the morning, and they have a big, large territory stroke. May eventually go on to need a decompression. And these are all big losses for a cerebrovascular neurosurgeon on a patient that came in with a good exam and went into surgery. So the goal of this project is to use some of the work that's been done in the SANS lab to get a better understanding of what can we look at in patient-specific factors to get a better understanding of what the flow looks like within the circle of Willis, and B, what happens during vasospasm. And going back to the two types of imaging strategies that we have that are non-invasive, we have the transcranial ultrasound, which will show you velocities and direction of flow. And then we have the CTA that shows you the magnitude of the vessels. A cerebral angiogram is kind of the gold standard, and that shows you both really well. And so the question is, can you recreate from transcranial Dopplers and from a CTA the same type and same quality of data that you would get from a cerebral angiogram? And then can you use that to then predict anatomically, based on patients' collaterals and based on the flow dynamics within various patients, who will go into symptomatic vasospasm and who will not? And that's kind of the ultimate goal of the project. So, talking about the objectives, the first is, the main overlying objective of this project would be to better understand the relationship between cerebral blood flow, hematologic anatomical factors for patients that have subarachnoid hemorrhage and go into develop cerebral vasospasm. That's basically saying what is causing, certain patients to have really bad vasospasm versus certain patients to have vasospasm, but being able to accommodate with, blood pressure augmentation. To do that, the first and the main specific aim of this project is, can you take TCDs and a CTA and create a virtual angiogram that can quickly show the various dynamics of a patient's circle of Willis, and can it be accurate? From that, can you then use this to try to predict which patients will go into bad vasospasm versus which patients will be able to accommodate with medical management? So in order to do this, we are planning on taking 30 consecutive patients that have had aneurysmal subarachnoid hemorrhage and trying to essentially take from those patients 15 patients, take as many patients as possible to have 15 patients that went to cerebral vasospasm and were successfully managed medically, and then 15 patients that ended up requiring intervention and then going to the angio suite. An important part of this project is defining cerebral vasospasm, which I think is something that is variable across institutions. And for us, We're going to use mainly our TCDs, and that would be looking at the velocities through the MCA being greater than 120 centimeters per second. Looking at the Linegard ratio greater than 3, which shows us kind of the ratio between the velocities in the middle cerebral artery versus the internal cerebral, the carotid artery. And then finally, looking at patients that have, high or significant magnitude of changes within a vessel's velocity. And that these all tell us, going back to kind of high school physics, that something is happening with the diameter of the vessel if all of a sudden particles are having to move significantly faster going through it. And that's kind of what we're using to define vasospasm. I'm not going to spend a lot of time going into the experimental design, but essentially this is a lot of work that's been done already in trying to validate a model that will essentially take variables from the CTA and variables from the TCDs and essentially take an array of measurements and then try to essentially figure out which is the most accurate of those measurements using a few different types of both Bayesian and sensitivity analysis to essentially take a spectrum of measurements and then basically determine which one is the most likely the best representation from that. And for the CTA, the reason that this is necessary is to kind of take the quality of data and it's essentially the pixels and try to essentially get an accurate measurement based on the pixelation of the study. And then for the TCD waveforms, it's because it's this continuous measurement where you get a multitude of velocities. So it's taking all those velocities and trying to figure out kind of these are the most accurate, these are the most likely velocities that are representative of the vessel. From that, you could use mass confirmation to basically understand like what goes into the system have to come out of the system. If you can do that, you can basically try to create a complete, like a closed system to create your cerebral angiogram, and that's kind of the end result of this project, and that kind of uses this computational fluid dynamic algorithm that's been being worked on in the lab. So, this is a representation of kind of the what a diagnostic cerebral angiogram looks like, and then this is the virtual angiogram on your right. The way that we would try to validate this in the study is have neurointerventionalists look at these and basically using a Likert scale try to determine how similar they are. If there's ones that it seems like is on the fence, we would bring in a third reviewer for a tiebreaker, and the goal would be to get a score of 4 or 5 and greater than 90% of the cohort. This, I think, is going to be the most challenging part of the project, and this is where I think there's the most opportunity of improvement. And the current methods and talking to some of the scientists that have been working on this, there's a lot of manual manipulation of this model. And, there's a lot of looking at the angiogram and then looking at the model and trying to kind of tweak the parameters to try to create a model that mimics the flow seen in the cerebral angiogram well. So the main goal of this specific game is to create a model that you don't have to do a lot of manual manipulation for, and then also create a model that you can efficiently do this over and over and over again, right? With the goal of eventually having a larger scale of data run through this model. And then second, this is the more of a stretch goal, but then it would be to take these patients that then required endovascular intervention and try to essentially predict their the changes in their flow through their their TCDs and their CT that were obtained when they went into vasospasm, and then compare it to the angiogram that they would get when they went for an angioplasty. And once again, kind of similar method where we would use we'd have the neurointerventionalist look at it, basically comment on the changes in flow, and then compare that to what we were seeing through our model. And once again, this is trying to validate this model. Then from there, this is where we then try to say, okay, we've got an established model. The model seems to work well. trying to look at a variety of different patients and try to understand from those models, is there anything that looks to be different? And then if we feel good about the model and we feel like we've actually validated it well, taking the patients that have TCDs and CTAs, but then just had medical management and trying to use the model to predict what their cerebroangiogram would look like and what their changes in flows look like, to see, is there a difference between patients that we're able to accommodate with changing their flow and changing the flow through their collaterals versus patients that we're not able to accommodate and then eventually needed to go to the angio suite for intervention.
And Zach, I'm so sorry. We're right about time. Is there a way, you want to wrap up in about 30,
I'm on the
60
last slide.
seconds?
Yeah.
Perfect.
So in summary, this is the goal of this project, is to, like I said, first and foremost, create a model that would standardize and be able to replicate a cerebroangiogram, and then to begin to understand the role of collateral blood flow and hemodynamics through the circle Wills in the setting of cerebral vasospasm. I think that, this is something that eventually using something like machine learning or artificial intelligence would be really helpful for. Big acknowledgements. Just wanted to thank the faculty, and a big thank you to Sharon Durfee for all of her help submitting all of these different grants throughout the last few questions.
Well, thank you so much. I'm so sorry. Yeah, we're a couple minutes over, so I think we're gonna have to move on. We'll have Zach's email. Please reach out with questions to Dr. Abakasis as he works to finalize this project and get rolling here soon in a few months. Okay, with the interest of time, and so that we give all of our speakers their allotted time, let's go ahead and transition to Pancho Ruiz Rodriguez. Pancho, are you out there? Am I seeing you? Thought I saw him. There he is. Fantastic. All right. You want to load up your slides?
Yeah, I'm setting it up right now. Okay.
All right. I believe as Pancho's loading up, we can kind of briefly enter and say we're going to switch gears here. And I believe here discussion on some of the functional neurosurgery, sorry, work that is done within our department. Focus primarily on language.
Okay, here we go. All right. So today I'm
Oh, and Pancho, there we go. Yeah, I was going to say not presentation mode. There we go. Okay. Oh, switching to epilepsy. All right.
Yeah.
Yes, we really appreciate being informed in advance, just because we need to do CME credit submission so that the admin staff actually can know and put that information in appropriately. But yes, see that you've transitioned to epilepsy. Okay.
That's right, Dr. McDonald. So this is a project that I've started with Dr. Ben Grannon. Yeah, our language project still keeps going, and Dr. Grannon's lab keeps increasing in size, and we have funding and new staff. But I want to touch base on this. I'm looking forward to working with thalamic simulation in the future. And this is a first step with patients with epilepsy that Dr. Grannon has implanted. So today we're going to talk briefly about responsive neurostimulation of the pulvinar nucleus of the thalamus for medication refractory epilepsy. So in brief, deep brain stimulation of the thalamus for epilepsy is primarily done today with the method of responsive neurostimulation, which has now become widely utilized method for treatment of medical refractory epilepsy. This is a type of DBS method that is used to treat to achieve seizure control, and different nucleuses of the thalamus are targeted. The volume of the patients in the literature that describe this type of treatment are primarily focused on the centromedian nucleus and the anterior nucleus of the thalamus. There is not a lot of literature, very little patient information out there for pulvinar stimulation. And because there's so few reports, we are working on trying to get the ones that we have out there and do a case series of 4 patients that Dr. Grannon is currently treated and have successful reduction in their seizures. So the deep brain stimulation for the thalamus, the places that we target are the anterior nucleus, the centromedian nucleus, the dorsomedial nucleus, and the pulvinar. Just briefly, so like here we have the anterior nucleus of the thalamus. Very commonly, we place leads in the centromedian nucleus, which is this small nucleus over here. This is the dorsomedian nucleus, and this is the pulvinar, which is the largest nuclear group subdivision of the thalamus. So in our case, we have a case series of 4 patients that were implanted by Dr. Grannon. All these patients follow up at HMC Epilepsy Clinic. 2 of them follow with Dr. Holmes. 2 of them follow with Dr. Hikimian. All of them have diagnosed posterior quadrant epilepsy of some type. This either by SEEG or scalp EEG. So these are patient groups. So 4 of them have at least 1 pulvinar RNS lead. All of them underwent extensive treatment trials prior to implant. All of them had failed medical management. 3 of the patients underwent intracranial EEG placement, and they confirmed non-resectable unilateral posterior quadrant seizure. The other patient was diagnosed via scalp EEG. The patients underwent unilateral pulvinar depth placement with additional ipsilateral posterior quadrant strip. And the reason that we keep mentioning posterior quadrant epilepsy is because the reason we target the pulvinar is the pulvinar's connection to the posterior aspect of the brain. So in this image, we can see here the pulvinar nucleus connects strongly with the V1 and V2 region, so the visual aspects of the occipital lobe, as well as the posterior inferior temporal lobe, which has strong connections also to vision. And patients who have refractory epilepsy originating from this region can be treated by stimulating the pulvinar nucleus. This is our patient group. So there's a variable ages of all sorts. The patients who are here, the adults who are diagnosed as adults, of them, they do have focal aware seizures. This patient who's diagnosed in infancy has different types of seizures. Sometimes absence, sometimes has focal aware. The seizure frequency varies among them. Some of them have multiple seizures per day. Some of them have multiple seizures per month. The seizure severity varies as well. Some of them are able to go about their day and they have jobs and so on. Other ones are pretty debilitated. We trialed multiple AEDs prior to the implantation, some of them 8, 7, 13, plus a VNS in the case of patient JH. All of them were not giving adequate seizure control. So for this, we implanted our leads, which are currently at these settings as labeled. And the patients had different types of results. Most recently, we have information from their clinic visits to the epilepsy clinic at HMC. And one of the patients has shown no seizures. The other patient, 1 seizure per month. Another patient says that their seizures are okay, has 4 in the last 10 days, but prior has had about 10 seizures per day. One of the complaints was that he was falling all the time. Now he rarely falls. And the overall quality of improvement for each patient has increased significantly. The goal of this case series is to state this in a careful way, and we're currently working on it to just highlight the usefulness of this type of therapy. And then once we submit this, we plan to go ahead and do additional studies with dynamic simulation. Right now, our conclusion is that early outcomes suggest that the pulvinar nucleus is a safe place for implantation, is a viable option for medical refractory epilepsy, for posterior quadrant epilepsy, and it's beneficial for seizure control, and especially for patients who've implanted for at least a year. Patients with more recent implants have shown some degree of seizure control, and as we said more recently, we've seen some of the effects about a year after that. The patients are closely monitored, and we continue to collect data. We're actually writing a manuscript right now and putting all these things together to try to put in a case series with and contribute to the literature with which is there's such great paucity on it. And with that, I thank Dr. Grannon for all his help, all his mentorship, and open the floor for any questions.
All right, we have about 60 seconds. Way to get us back on time. Pancho, any questions from folks out there? I'll just ask a real quick one, which is, the age range really caught my eye. Do you think that there's a role with some of just the implications of when it was caught, when it started, and as those individuals were going through development and the kind of formation of many of the functions? Actually, nice pop up from Dr. Rapport, including things like effects on language.
Yeah. So one of the things is definitely the modality. So the patient that was diagnosed in infancy is a patient that was diagnosed with scalp EEG, and those kinds. That patient has one of the most severe and difficult aspects of his life throughout development. The other patients who were diagnosed in adulthood, most of them are doing okay. In terms of the effects on language, we have to delve a little bit more. Most of the patients that, 3 of the patients at least are aware and able and communicative. One of the patients is a little bit disabled from what I'm reading in the charts. But I think that primarily what we want to do is to put in results out there, because there's very little on these patients. And we just want to make our little mark and try to expand the literature in that sense.
Okay. All
If
right.
I could just
well,
add real quickly on Dr. Rapport's question. I think it opens up this whole area of implanting into the thalamus with stereo EEG and then subsequent RNS implantation. Andrew and I have been doing, and it really brings a nice opportunity to study effects of stimulation in the thalamus during the intracranial investigation on things like language. As many of us know, Dr. George Ogerman saw episodes of anomia when stimulating in the thalamus, and we've been starting to do more and more pulvinar stimulation, and Dr. Ogerman's work was specifically within the pulvinar as a way of studying the interactions between the thalamus and posterior quadrant, basal temporal, lateral temporal sites in the setting of a language type task, and how that affects long-term cognitive language ability in these patients. So it's a nice way to study this at the time of implants, at the time or chronically with RNS. And so we have a lot of opportunity to look into that.
And with Dr. Grannon's comment, I would say, the question I think for me is also, does it impact, considerations of rehabilitation? If you, knew more about that, would that help you in focusing in on some of the just OT work that is often done with these patients? So on the rehab side. Okay, fantastic discussion. In the interest of time, I think we should keep hurtling through on to the next speakers. Next up is Dom Nistal. Dr. Nistal will take us back into the vascular realm and tell us about his work in NETs and ischemic stroke. So I'll turn it over to Dom for his presentation.
Excellent. Thank you. 1 second here. Can everyone see my screen?
Coming in perfectly. Yep.
Perfect. Okay, great. So what I'll be presenting today is the project which I have submitted for funding for my research year. It's entitled "The Role of Neutrophil Extracellular Traps in Acute Ischemic Stroke Severity and Influence on Treatment Failure," with my primary mentors being Dr. Levitt and Dr. Chen. The objectives of the project include understanding the role of the utility of NETs and neurologic disease, and I'll go into detail kind of what that is for those who are unfamiliar with what neutrophilic and the extracellular traps are, specifically in their involvement with neurologic disease and ischemic stroke. Then to hopefully define the relationship between NETs and the severity of stroke, both clinically and radiographically, and then identify potential targets for treatment. Kind of as a long-term goal and secondary and tertiary projects down the road. So some background for the project. The gold standard of ischemic stroke therapy, as all of us know, is timely reperfusion, either chemically or mechanically with thrombectomy. There are a large subset of patients that we see at Harborview and across the country who are either not candidates for thrombectomy based upon the window of presentation or other indications that lead to them not being able to obtain these, as well as patients who fail these treatment therapies. Despite the large and overwhelming success of thrombectomy, there's still patients who either fail reperfusion or occlusion after treatment, and those are patients that are targeted for new therapies. New data has suggested, particularly over the past 5 to 10 years, that neuroinflammation, both after ischemic and hemorrhagic stroke, may play a really significant role in the variability of patient outcomes in the long term over time. And some of my work originally in medical school was looking at this environment, not specifically with neutrophil extracellular traps, but with the neuroinflammatory environment around hemorrhagic strokes. And that's kind of what led me to this project. And so first, to kind of go into detail a little bit about what these are and how they influence the brain, because it's something that's been studied throughout the entire body and different disease processes. So a neutrophilic extracellular trap was first described in 2007 in infectious disease, and kind of broadly, it's when neutrophils are activated for whatever reason, but initially looked at in infectious disease, of course, where the neutrophils then release granule proteins and chromatin to form these extracellular fibers that bind to pathogens and kill them. You can imagine that this is a schematic, and I'll kind of go through this step by step, but you can imagine that creates an inflammatory process as well. And an infection, that's a very beneficial thing, but in the brain, it can be detrimental and have neurotoxic effects. So at first, there's an ischemic event, which leads to the recruitment of neutrophils. This has been studied to show that there's a large increase in recruitment of neutrophils, particularly in ischemic stroke in the brain tissue around the ischemic area. The neutrophils then recruit various factors, cytokines, plaques, reactive oxygen species, etc., to then release these granulocytes to release the neutrophilic and extracellular traps. So that's these little kind of bean type structures that are coming out of the cells here are the nets. Extravascularly in the brain parenchyma, that can lead to neurotoxic effects, activates microglia, which you can see here, and then as well as enhances further inflammation and recruitment of other inflammatory products. And then intravascularly, it can lead to the activation of the coagulation cascade, as well as thrombi formation and damage of the blood-brain barrier, which can lead to either progression of ischemic stroke or the failure of recanalization after reperfusion therapies. Neutrophilic extracellular traps have been studied in both translational and human models, particularly in neurologic disease and ischemic stroke. And so some of the early translational models have shown that both ischemic stroke thrombi and perilesional brain to the mice post-mortem have evidence of net markers in this tissue. Markers of net formation, some of which I'll be hopefully studying, include H3-CYT and MPO DNA, are upregulated in stroke patients in the plasma, and as well as in the mice. And so this is a study that specifically looked at 27 patients per group, both ischemic stroke patients compared to healthy donors, and just looking at the expression of these markers and the clear elevation. DNase is an enzyme that breaks down a lot of these markers and is one of the main components that reduces the inflammatory process associated with neutrophilic and extracellular traps, and that is downregulated in stroke patients. Looking further at these translational models, this is a mice model where they looked at a transient occlusion model for mice, where there's 1 hour of transient occlusion followed by 23 hours of reperfusion for the mice. And before the onset of stroke, they provided the mice with GSK 199, which is a PAD4 inhibitor, and it's one of the inhibitors for the enzyme that leads to the breakdown of nets. And then also looking at DNase1, giving that as a treatment before the stroke versus a vehicle or placebo. Concentration of the net markers were increased in the mice with stroke. And then if you look at the patients who were treated, or the mice that were treated with these inhibitors, they had significant decrease in the markers of net formation. And then if you look at the actual infarct volume, which is panel B, you can see the vehicle mice have a larger infarct volume, that white tissue that's outlined by the black dots, compared to those that were treated with these inhibitors of net markers. Demonstrating that there's a significant reduction of infarct volume if you can target these nets, or these neuroinflammatory cell granules that affect the ischemic tissue. They also looked at neurologic exam and neurologic outcomes for the mice. They looked at a Betterson score and a grip test score, which are different ways to evaluate motor strength and neurologic outcome in mice. And there was an improvement compared to the vehicle mice in their overall outcome. This has also been studied in humans in stroke. This is just looking at a broad group of 243 patients with ischemic stroke compared to healthy controls. And the level of net markers in ischemic stroke patients is significantly elevated compared to those of controls. And then looking at the correlation with these plasma levels of CYP3, cell-free DNA, and other markers of net formation, you can see that there's a clear positive correlation that is associated with worsening NIHS stroke scale being associated with higher expression of these markers of net formation. In addition, there's they dichotomized or trichotomized these groups into severe, moderate, and mild stroke, and you can see that the severe strokes have a significantly elevated expression of these markers.
And Dom, we have about 60 seconds.
Okay. Oh, sorry. Great. No,
So
no,
if
I'll
it's
just
possible, wrap up
yep.
in 30 to 60 seconds. Yep.
Perfect.
Just give
Yep.
speakers time. Mhm.
Yeah. No, anyway, so my hypothesis is to assess if there's an increased expression of these markers in patients with stroke, and then to eventually determine if there's a treatment target in these in this patients based upon this, specifically looking for an opportunity to affect the patients that fail reperfusion. So specific aim looking at the association, and the specific aim number 2, looking at patients who undergo reperfusion with thrombectomy and seeing if there's an association between nets and patients who fail recanalization therapies. We'll kind of skip the limitations, but there's a number of limitations with a study like this, mostly from a volume standpoint, but hopeful to meet
Great.
the similar studies in the past.
Thank you so much. Yeah, again, apologies, folks. We're just trying to try to give every speaker their amount of time. So to the speakers that come after, any questions for Dr. Nistal, please email Dom and reach out as he embarks upon this project. Very, very exciting work. Okay, I think in the interest of time, we're going to have to move on and we'll go on to Dr. Carroll. And Kate Carroll will be telling us about, I believe, if I remember correctly, an update to some of the work she did under her R25 and looking at depression and some of these vascular disease states. Although, Kate, if you're speaking, we can't hear you. I'm not sure if you are muted.
I was not speaking. I am.
There we go. We've got you. All right. Thank you, ma'am.
All right. Thank you. Yes, I will be talking about a brief update on the work that I did as part of my R25 research year. And I know everybody's heard this talk before, so I'm going to try and focus on what we've done this year as opposed to spend as much time in the background of the study. But briefly, this is on the role of the HPA axis in predicting mental health outcomes after aneurysm rupture. I have several grants funding my research. And again, briefly, we all know at this point that depression is an unfortunate common side effect during the recovery from aneurysmal subarachnoid hemorrhage. Meta-analysis on over 6,000 patients found a frequency of about 30%. Typically, this is a mild to moderate depression, and there is not great consensus about who is at risk for developing this. Not a lot of risk factors actually stood up across the meta-analysis, but what does predict it is that it is actually aneurysmal in nature, and that patients who have a prior history of some sort of psychological disorder are more prone to mental health problems after aneurysmal subarachnoid hemorrhage. Some people have begun to explore whether there are genetic risk factors that make some people more likely to develop depression after subarachnoid hemorrhage. This is a study that was a retrospective cohort study done in England that looked at all surgically treated ruptured aneurysms from a single institution treated over a decade. They identified 125 patients. And then retrospectively went and interviewed all of these patients about how often they had experienced depressive symptoms over the last month. So the time point at which these patients were evaluated was quite variable. They also at that point collected venous blood for genotyping. And what they found was that for corticotropin-releasing hormone receptor 1, there were several polymorphisms where if you had more penetrance of the minor allele, you overall had much better quality of life scores, as well as improved protection against depression. Whereas if you had more of the major allele, your quality of life outcomes in general were worse. And so why is this? There's extensive research done on the HPA axis and depression. In patients with depression, just to summarize some of the literature findings, we see desensitization of glucocorticoid receptors after prolonged elevated glucocorticoid and corticotropin-releasing hormone. People have found elevated levels of corticotropin-releasing hormone in the CSF, which actually then normalize with appropriate treatment of depression. These patients respond abnormally to low-dose dexamethasone suppression. And again, this normalizes with adequate treatment of the depression. And in post-mortem studies, they have found decreased CRHR1 expression in the anterior forebrain. This has led people to look at the relationship specifically of CRHR1 genotype to the risk of developing depression. And in multiple populations, those who have sustained both physical and psychological trauma, there is a significant relationship between between genotype of CRHR1 and the risk of developing depression. Why is this? I think our understanding of this model can be greatly informed by post-ischemic stroke depression. The idea being that an acute stroke causes significant stress on the body. This activates the hypothalamic pituitary adrenal axis, resulting in increased production of glucocorticoid, CRH, ACTH. And corticotropin-releasing hormone, in addition to activating the downstream effects of glucocorticoid production, has effects within the brain itself, specifically reducing BDNF transcription. And this results in structural changes in the brain, including ones that we see in depression, such as volume reduction in the hippocampus, amygdala, and anterior forebrain structures. So to further investigate this, I have been running a single institutional observational cohort study. The goal is to recruit 30 patients. We've been including adults who have a ventriculostomy, present with a Hunt and Hess score after ventriculostomy catheter is placed of 1 to 4. Unfortunately, who are English speaking, who present within 48 hours of their ictus, and who have truly aneurysmal subarachnoid hemorrhage, and non-infectious or traumatic aneurysms. Our study design is that during the course of their hospitalization, we collect serum for CRHR1 genotype measurement. At 4 time points throughout the hospitalization, we collect both CSF and serum to measure BDNF and CRH. And then during follow-up at several time points, we collect PHQ-9 and HAM-A surveys to quantify or screen for depression and anxiety, as well as measure salivary cortisol. Enrollment began at the end of 2023. And since then, we have had 78 aneurysmal subarachnoid hemorrhage patients present to Harborview. Of these, 41 patients were eligible for the study. 7 declined once approached for consent. And 17 have been missed due to when they presented and the availability of staff to collect samples. And so 17 patients were enrolled, 2 of whom died and 2 of whom withdrew at later time points. So at this point, 13 have completed the hospitalization component. We have 6-month data on 6 of them and 12-month data on 4 of them. We wound up skipping the 6-week time point because patients in general have not recovered to the point where they are able to participate reliably in this time point. There's not much surprising about our demographics. The median age was 60. A majority of our patients are female. A majority of our patients are white. There is a high proportion of current and prior smoking. The median Hunt and Hess score for our patients is 3. About half actually had a history of depression. Many have vasospasm per TCD criteria identified, but only a quarter of them have actual delayed cerebral ischemia. And the median discharge MRS score is 3. We have, at this point, screened a handful of patients for both depression and anxiety at our 6-month and 12-month time points, and found that by 6 months and then increasingly at 12 months, patients are screening positive for mild depression and mild anxiety, and we see a trend of this increasing severity with time. We are reaching the point where we're going to be able to submit our first batch of samples for testing, but we're waiting until an N of 20 in order to run the ELISAs, because we are developing these methods in-house with our lab medicine director, Dr. Hoofnagel. And I will keep it short and sweet. I'd like to acknowledge everybody who's participated in this project, who's made it possible for it to keep going while I return to clinical duties. Thank you.
Thank you, Dr. Carroll. All right. Any questions out there for Kate? We actually do have a couple minutes. Thanks for getting us back on track. I think,
Hey,
one of the... Oh, yeah,
Kate,
sorry, go ahead.
quick
Great.
question.
Yes, Dr. Levitt.
Oops. No, go ahead.
No,
was it
I was
Christoph?
great.
Christoph, did you have a question?
No, my question was, Kate, I think this research is very fascinating. I was wondering if you have a control group of patients that have another traumatizing event like TBI or, chronic pain or something else, so that we can see if there's a specific underlying pathophysiology that is really sort of, that could be, linked with subarachnoid hemorrhage and sort of, CNS changes that you see with that.
I think you've hit the nail on the head. That is the question. This study is really a feasibility study, and because of the role of the cerebrospinal fluid, I tried to limit for homogeneity of the study to start to develop the method. But I think the question is going to be, after we've established that we can do this, to expand to different populations. I also began work with the TRACK TBI group to look at, because they have this data, they have CRHR1 genotype, and they have imaging data and depression outcomes in a handful of patients, to look at the relationship in TBI patients, and hopefully can finish that soon. So there is no control group in this study, but I think that is an important next step, because my theory is that it's not limited to stroke patients per se. There may be a unique aspect to the stroke component, but I think that the role of CRHR1 is probably not unique to stroke.
Dr. Levitt, I think we heard you pop up,
No,
if you're still there.
That's fine. That was actually my question, which was, how do you take what you've learned in this subset of patients with aneurysmal subarachnoid hemorrhage, which we've talked about extensively, obviously, and generalize it more broadly, or take the methodology and the concept that you've learned and apply it to different disease states that may also have mental health problems? Because I think this is the area that we ignore as neurosurgeons, which is the intersection between a neurosurgical disease or neurological disease and mental health, which we know is very important. But when we do our exams and the patient looks great following commands times 4, ANO times 3, we just skip over everything else because we don't have the training and it takes too long and all that stuff. But obviously that has a huge impact on quality of life. So mining this area using these quantitative or biological basis techniques, but studying different disease states, I think is going to be a really interesting future area of study.
Thank you for those comments. Yeah. Okay. Well, fantastic work. I think in the interest of time, we will move on. We're right at the top of the hour. So we'll transition to Dr. Eaton, and Jess will be telling us about her work, I believe, as well as from a prestigious award she received with the Cooney Foundation. So another grant-funded resident here.
Okay, all right, good morning. Thank you all for the opportunity to talk today. My name is Jessica. I'm one of the R6s, so I did my research here last year. I'm going to be presenting my work that I did in Dr. Ferreira's lab on the genomics of chondrosarcoma. So I actually presented the beginning of this work and then some of the preliminary data last year. So I'm just going to briefly go over some of the background information, touch on the relevant previously presented material, and then present an update on the additional data and analyses we've done over the past year, and then talk about some of our future directions for this work. So again, in brief, chondrosarcomas are slow-growing but locally invasive tumors that occur all over the body. Skull-based chondrosarcomas in particular are very rare, making up only 1% of all chondrosarcomas. They can range from WHO grade 1 to 3. They do have the ability to metastasize to other parts of the body. The current gold standard treatment is maximal safe surgical resection. Radiation after resection does reduce 5-year mortality by about 50%, but the overall recurrence rate for patients with skull-based chondrosarcomas at 5 years is still over 30% at this point. So the current project was actually born out of 2 patients of Dr. Ferreira's and Dr. Cranmer's, who is one of the sarcoma doctors that have undergone treatment with ivosidenib, which is an IDH1 mutant inhibitor that is already on the market, used to treat cholangiocarcinoma and AML. So last year, we talked about the role of IDH1 mutations in cancer and looked at the preliminary testing of our skull-based chondrosarcoma cohort. Over the past year, we've performed whole genome sequencing on the cohort to broaden our view to include more mutations, and found a whole host of new findings that provide opportunities for further investigation as well as possible treatment options, and that's what I'm going to go through today. So we use the tumor bank to review all patients who have undergone surgery for skull-based chondrosarcomas. We had a total of 35 tumors from 30 patients, and then we performed chart review to collect clinical data as well as whole exome sequencing on the frozen tumor tissues and matched blood samples. So this is our clinical data. Mean age was around 50 years old with a fairly even split between men and women. About 70% of the tumors were petroclival. Most patients underwent craniotomy as opposed to ETSS. And then gross total resection was only possible in about 26% of cases, with 63% of cases having subtotal resections. And then 86% of the tumors were WHO grade 2. So this is a look at some of the Kaplan-Meier curves we generated. These are the ones, with the exception of this top left one, which shows the survival curve for the subgroups based on molecular profiling, which I'm going to show you on the next slide. These are the 5 that were significant, which is why they are the ones that are displayed. So in the top left of this figure, you'll see a list of 25 known cancer-driving mutations that were identified in our cohort. So the length of the horizontal bar shows the frequency of mutations among the cohort, with IDH1 obviously being the most common mutation at 83% of the samples. While isolated IDH1 mutation status did not predict outcome, mutations in DOC8, SETD1, PATCH1, and WNK2 all provide a more favorable outcome if the mutation is carried by the tumor. And Notch3, which is this one in the bottom right here, actually provides a poor prognosis when that gene is mutated. So interestingly, we found that the cohort divided itself into 4 molecular subgroups based on IDH1 mutation and overall mutation burden. So on the inset figure, you can see that this entire left side here is IDH1 mutant tumor. So there's one group with extensive other oncogenic mutations on the far left. And then the ones next to those are IDH1 mutants, but they are not that mutated in terms of the other mutations. The other, on the right side, are 2 groups of IDH1 wild-type tumors. Half of them are heavily otherwise mutated. Half of them have a very low mutation burden. And then the bottom 4 bars on this figure are a representation of clinical aggressiveness. So marked there is recurrence, mets to other parts of the body, invasion, and mortality. So none of these ended up being significant just because of the sample size of the study, but you can see that there's a lot of red in both of the IDH1 wild type groups, as well as in the IDH1 mutant low mutation burden group. So there are certainly a lot of questions to ask in response to this. The amount of genetic molecular heterogeneity is somewhat surprising. Warrants further investigation into how this might affect prognosis, but also what mechanisms might be at play to create these differences in genetic makeup of the tumors. Understanding the mechanisms will help us be able to better approach new treatment options for these tumors. In addition, seeing the different oncogenic mutations presents a lot of great opportunities to investigate therapeutic potential of several different drugs that have already been developed. So in this bottom figure, you'll see our 4 subgroups with the relevant genes that we found in green, and then the purple circles represent drugs that target the mutations that are shown there, with the red lines representing therapies that upregulate and the blue lines representing therapies that downregulate the relevant genes. So a lot of options to look into. So these are the current projects that are in follow-up in Dr. Ferreira's lab. They are looking at ivosidenib drug response, both in wild type and IDH1 mutant chondrosarcoma cell lines, looking at the mechanism of IDH1 mutation and chondrosarcoma progression and drug response by using single-cell sequencing techniques, investigating whether we can detect IDH1 mutation in liquid biopsy, and then doing spatial transcriptomics in an unresponsive case of chondrosarcoma that was treated with ivosidenib. So we had the 2 successful cases, and those patients still are not having any progression, which is great, but we have another patient that we treated and she did not respond to the therapy. So that's another thing to begin to investigate. So these are my references and I will stop there.
Fantastic talk, Jessica. That's wonderful and just really exciting to see where this has gone and all the tremendous work that you and others have done on this. Questions? We do have a couple minutes. Thank you for keeping us on time as well. Any questions from the group? I guess I just have one, which is just to say, what you're highlighting, I think is so crucial, which is, for as much as, we've advanced in many of the kind of disease conditions that we all think about and work with and patients that are seen, gosh, it's complicated, right? I mean, it seems like more and more that we dive into this, it's not finding that correct subgroup or phenotype or endophenotype. It's just, wow, there are even further, kind of breakouts and considerations. Have you guys thought about, just trying to leverage technology? I assume the answer is something's in the works, but how to, really take that and, I feel like that begs almost like an informatics or somebody, computational or somebody to really, work with you as the clinician and to take that data and say, this is how we could use this in practice, how to, really get to the level of precision medicine, per patient, exactly to your point earlier.
Yeah, I think actually the Dr. Ferreira's kind of meningioma efforts are a lot more kind of in that vein. The part of the hard thing about chondrosarcomas is there's just not that many. So it's hard to find a big enough group to even like run it and be able to find general things that would allow us to take that approach.
That makes sense. Yeah. And then the push for our informatics colleagues would be, how to do that on a per patient basis.
Yeah.
Take the high dimensionality of data on that specific patient and figure out the combination exactly as you just showed of all the potential drug targets, all the potential drugs out there, and to create that almost therapeutic milieu that would be specific for that patient with
how to figure out which one goes with which one. Yeah, totally.
Yeah, the up and down regulation combination. Okay, well, fantastic work. You guys are really moving us forward in new ways that just we never would have appreciated without these efforts. I think in the interest of time, we'll move on to Dr. Barrows, another funded R25 and Dempsey. Gosh, Gil, you're hitting it out of the ballpark here. That will be telling us about work he has done over the years. He's been with us as we are almost there to bid him adieu off to New York, it sounds like, as a PGY7.
Right. You guys can see my screen and everything?
Coming in great.
Okay. All right. So yeah, this is my work that I did with my R25, and I've been working on this, for the past 3 years. Some of these slides I presented already before, so I'll go through them quickly because I want to get to the actual data. So flow diversion treatment that we've been using quite extensively, both at our institution and across the country and the world for aneurysms. It's pretty successful with a relatively low complication rate, but there's still a lot of patients that require retreatment, up to 8% by 2 years. So, there's still a question of how can we make these devices better and what are the mechanisms that are driving endothelial cells, smooth muscle cells, and other cells in the vascular physiology and the pathophysiology behind that. So from the CFD side, we looked at how wall shear stress and other hemodynamic parameters are affected by flow diversion. This is data from catheter angiograms pressure measurements. So you could see here in the untreated model on the left, the aneurysm has higher wall shear stress experience within the dome, and after treatment, it's much lower. So we know there's definite hemodynamic changes that occur in the aneurysm before and after treatment. And then from prior work done in Levis lab before I started this work, we know that different areas of the parent vessel and even within the aneurysm have different levels of genetic expression. And this kind of laid the groundwork for my study, which is how can we see what the genetic changes are before and after treatment with flow diversion, and correlating that to the CFD data that we had. So some of these slides I shared before, but just to refresh everybody. So these are the models. These are lined with endothelial cells. And you could see there the confluency of the cells, both in a magnified view and also a bit demagnified. This was kind of an internal quality check just to make sure each model had good cell seeding. This is after stent placement. You could see there the cells within the stent, around the stent, and also just a gross view of the aneurysm there and the stent going through the parent vessel. Another view, this is the aneurysm dome, so just outside of the stent itself, and the cells lining the dome. This is the experimental setup, so you could see the cell media perfusing the pump, and each model had this for about 24 hours running. And then afterwards, I would isolate the domes and then submit them for RNA sequencing. So now let's get to the data. I want to spend some time on this. So this is just a chart. Each individual gene is not so important, but these are just some of the noteworthy genes that I picked out. There were no significant differences between the untreated and treated conditions for the proximal parent vessel and the distal parent vessel only had a few changes. So we really focused on the aneurysm domes, which did have 366 statistically significant gene changes between the two conditions out of 13,900 genes sequenced. So I looked at the whole list of all the significant genes and just picked out a couple that were relevant to vascular remodeling and angiogenesis and made sense to comment on. And positive log fold change demonstrates upregulation in the treated samples, while negative log fold change is downregulation in the upregulation in the untreated samples. FDR, you can think of like a p-value. So these are just showing the statistical significance. A better way to represent this, this is a volcano plot. This shows that same data that I was showing before and just highlights the noteworthy genes that I had in the table. These are all the genes that we had. So the 13,000. The red, each dot is a gene. The red dots are non-significant. The blue dots are significant. Like I said, FDR is like p-value, and the log fold change you can think of as the amount of expression. It's a way of conveying that on a logarithmic scale. So you can see there's definite changes between the two conditions: negative, untreated, positive, treated. This is a heat map again showing the differential expression of the genes. This heat map specifically looks at those genes that I plotted in the chart there because they make biologic sense. And this looks at the counts per million. So this is another way of demonstrating this data. And you could see there's clear differences between the groups. The left side is the untreated, the right side are the treated. So the genes that were upregulated in the treated condition are in the bottom half of the screen on the right, so the lower right quadrant. And then the genes that were upregulated in the untreated condition are in the upper left, and then vice versa for the other areas. And then this is a way of looking at the gene expression data. So this is a volcano plot of the gene set enrichment analysis. So this uses gene ontology terms, which bins genes based on their biologic function. So you could see that it's a little bit hard to read maybe, but there's like endoplasmic reticulum, lamellipodium, basement membrane, cytosol, ribosome. So based on the function of the gene, they're binned into that category, and this looks at more of a global view. So in the untreated condition, there were more geo terms that were related to cell adhesion, growth, cytoskeletal organization, and calcium binding. And this is probably, this is what we're kind of gleaning from this, is that it's like due to the blood flow's increased forces, such as wall shear stress that I demonstrated before in the CFD, experienced by the endothelial cells in the untreated aneurysm, could result in increased extracellular matrix turnover, which has been linked to aneurysm growth and rupture risk in prior studies. Versus in the treated condition, most of the terms that were enriched were related to endothelial cell proliferation, migration, coagulation, protein activity, splicing, and folding, as well as inflammatory chemoattraction. And this, we gather, is from a proliferative response by the endothelial cells due to more favorable hemodynamic conditions, allowing for inflammation-mediated healing, endothelialization, and luminal remodeling around the scaffold for sustained aneurysm occlusion. So that's our, kind of what we gathered from this, all this data. So, why does all this matter? Why does all this data matter? These are kind of the first steps towards understanding what are potential molecular targets for developing endothelial cell and eventually, smooth muscle and other components of the microenvironment to improve these devices to treat aneurysms. And, this is obviously very preliminary work, but, this is how you start this process. So just want to leave it up for questions and want to thank everybody in the Levitt lab and all the people I collaborated with, especially Fred Hutch, as well as UCLA.
Thank you, Gil, so much. Again, it's really extraordinary work, and you're right, it's foundational, but it's really important steps. And another condition where, gosh, it's complicated. Questions, comments from the group, since we've got a couple minutes.
I'll jump in. So Gil, it's a great foundation here, and you've taken a really multifactorial and complex project and managed to see it through to its reasonable conclusion. So what's the next experiment you're going to run? What's the next hypothesis you're going to have? Like, where do you take this? You've got some preliminary results here. Obviously, it'd be nice to do this with 10 times as many models. Yeah. That's fine. But like, where's learning what you did from this process? What's the next step?
Yeah, I think the next step is to understand how the cells interact with the other kinds of cells. I think figuring out how to layer the cells with smooth muscle would be very interesting. Building upon the different layers, because this is obviously just one cell layer within a model, and in real life it's much more complicated than that. So I think trying to understand how the other cells affect each other would be very interesting, and also figuring out how to do it on a single cell level. This was bulk RNA sequencing because we only had one cell level. So I think utilizing multiple cell layers and using single cell sequencing to look at different areas of the aneurysm as well as different areas of the parent vessel would provide a different level of granularity that we just didn't have here. But I think, this is the groundwork for that.
And Gil, do you think, I know I asked Julian a similar question earlier, but I think it would be potentially relevant here. Do you think that, potential vascular disease conditions, even just like the plaque buildup on the inside would, change how this would inform treatments? Just meaning like what you would be able to target, given, there will be likely spots that, can you get through that to what you would need to target for these therapies? Yeah, exactly. I think, if you're able to create some pathology, our pathology in this was the aneurysm. So that was our basis for the model, was the anatomic shape of the aneurysm gleaned from the 3D angios. But exactly, I think you could tailor it to different pathologies as well, like you said, like stenosis, like carotid stenosis, or other AVMs or other more complicated pathologies as well with these models. And then the last one to ask you is just on, kind of the overall vessel mechanics side, with so much of the flow information that you have. And it sounded like you were going to interrogate, different areas of the aneurysm. Do you imagine that in so doing, you would find essentially localized changes in some of these kind of targets because of the kind of growth and progression of the aneurysm? Yeah, definitely. In untreated conditions, we definitely know that already, that different areas within the aneurysm already have that different changes. So I think certainly that would be the case with this as well. So I think that would be
kind of like the next step is like focusing on different areas like within the lesion.
Gotcha. Okay, fantastic. Well, we are right on time. Much appreciated to the speakers for keeping us on time. I think we will transition next to Maddie Grail. Dr. Grail, another PGY7. I cannot believe, oh my gosh, you guys are almost out the door. We'll be heading off to Utah, but will be telling us about some work she did, I believe, with Track TBI. Super excited they were able to leverage that. And also somebody who I want to acknowledge was a multiple grant recipient with Adler, also R25, and then even the VA, Maddie, if I remember correctly. So Mon, congrats on some excellent academic neurosurgeon scientist track you were laying for yourself in launching your career as a spine and trauma surgeon. So I'll turn it over to Dr. Grill.
Great. Thank you, Dr. McDonald. As mentioned, I'll be talking about a study that I did using data from the Track TBI study. So this is about the use of EVDs versus intraparenchymal monitors in severe TBI. So as you all know, the Brain Trauma Foundation recommends that the information from ICP monitors is used in the management of severe TBI, but doesn't give any guidelines as far as which monitoring device they suggest that we use. The two most common devices used to measure ICP in TBI patients are an external ventricular drain, or an EVD, and an intraparenchymal monitor. As you all know, EVDs and IPMs differ in terms of the cost of the device, as well as related complications of placement, and there's some debate within the field as to whether device selection is associated with better functional outcomes. As you know, at Harborview, we typically use intraparenchymal monitors, but lots of institutions place EVDs in most of their TBI patients for similar reasons. So the objective of this study was to determine whether the use of an EVD or an intraparenchymal monitor for ICP monitoring is associated with better outcomes in patients with severe TBI. We included patients who were 17 years or older at the time of injury with severe TBI, so GCS 3 to 8 in non-penetrating injuries, who underwent placement of either an EVD or an intraparenchymal monitor within 24 hours of arrival to a Track TBI study center, and then compared groups both before and after propensity weighting, which we did in order to try to better balance the groups, since monitor placement was not randomized. It was just up to the clinicians treating the patients at the institution. Our final patient cohort had 189 patients. 115 of them had an EVD and 74 had an IPM. We had 16 different Track TBI sites that we found patients from for this study. The average age was pretty similar between groups, around 40 years old, and approximately 75 to 80% were males. In terms of the initial injury, the GCS of patients in the ED for the EVD group was significantly higher than that of patients in the intraparenchymal monitor groups of 4.6 versus 3.8, which was significant. When we were looking at outcomes, we were looking at the 6-month GOSE TBI. We were also looking at the percentage of patients discharged alive and their length of stay. There was no significant difference between the GOSE TBI and the EVD versus the IPM groups. And then a greater percentage of patients who were monitored with an EVD were alive at the time of discharge, 83% versus 69%, but that difference was no longer significant after propensity weighting. And again, the EVD patients had a slightly higher GCS in the ED. The hospital length of stay for survivors was similar for both groups, and there were no neuropsychological outcome differences between the groups. When we were looking at this, something that we also wanted to look at, given that the monitor choice wasn't completely random, and there were some sites that primarily use EVDs and some sites that primarily use intraparenchymal monitors. As one of our sensitivity analyses, we divided patients by the site that they were at and whether or not that site typically uses EVDs versus if they typically use intraparenchymal monitors. And so if you were at a site that was, 90% EVD use and you got an intraparenchymal monitor, in this part of the analysis, you were grouped as an EVD site person and vice versa. So for patients from sites that favored EVD, the ERGCS was higher than for sites favoring an intraparenchymal monitor, so 4.7 versus 3.5. And we were not able to correct that with our propensity weighting. The mean 6-month GOC TBI was 3.6 for patients who were treated at institutions primarily using EVDs, compared to 2.9 from those at sites primarily using intraparenchymal monitors. And patients who were at primarily EVD sites were also more likely to be discharged alive, 84% versus 69%. Following our propensity weighting and adjustment for the EDGCS, the 6-month GOC TBI remained higher for patients treated at sites primarily using an EVD. But the difference in patients as far as who was alive at discharge was no longer significant. Something else that we did to try to figure out whether or not our patients were lining up with kind of expected outcomes was to look at the impact and the crash predicted outcomes for all of our patients through their available calculations. So the 6-month morbidity for our total sample was well aligned with the 6-month morbidity predicted by these models. In contrast, when we looked at the predicted mortality at 14 days from the crash calculator, the sample had a predicted mortality of 32% for the total group, which was 30% for the EVD group and 34% for the intraparenchymal monitor group. But the actual mortality of our group was 16% for the total cohort, 13% for the EVD group, and 23% for the intraparenchymal monitor group. So our actual mortality was about half of what was predicted. As far as 6-month mortality as predicted by the IMPACT trial, the prediction would be 46% for our full sample, 45% for the EVD group, and 48% for the intraparenchymal monitor group, compared to actual mortality rates of 28% for our full sample, 23% for the EVD group, and 38% for the intraparenchymal monitoring group. As many of you know, there was a prior study by Dr. Bales et al., including many of my mentors who worked on this study with me, who found favorable outcomes with the use of intraparenchymal monitors compared to EVDs in 6-month GOSE, as well as lower in-hospital mortality and better scores on neuropsychological measures at 6 months. His study was looking at data from the COBRIT database, so the acetylcholine brain injury treatment trial, which was an interventional trial, but one that didn't find any difference with their intervention. He also, from a method standpoint, included patients who had both types of monitors placed within the first 6 hours in the EVD group, whereas in my study, I excluded the small number of patients who had both types of monitors placed. Patients in Dr. Bales's trial, is when he was looking at this, had a higher 6-month GOSE for the IPM group at 4.9 versus 3.8 for the EVD group. And we had a GOSE of 3.2 for our intraparenchymal monitor group and 3.6 for our EVD group. As far as when they looked at predicted outcomes with crash and impact, for his study, EVD patients had a similar morbidity for their outcomes. The patients who did not have an EVD had better than predicted outcomes. In our study, our morbidity outcomes were similar to those predicted. And then for mortality, the EVD group had a rate about 50% of expected, whereas the intraparenchymal monitor group had a mortality of about 70 to 80% of what was expected based on predictions. Obviously there could be differences in the patient populations or in TBI management. His study, was based on a database from an interventional trial. So even though they didn't find significant differences based on their intervention, it was kind of more of a controlled environment, whereas the TRACK TBI study was looking at how patients did based on how they were treated up to the clinicians. There could certainly be significant differences in patients who receive EVDs versus intraparenchymal monitors, such as clinician decisions to put in an EVD if a patient has IVH, or to avoid an EVD in patients who have more mass effect or smaller ventricles. And then also differences in how providers manage EVDs at different sites. at some sites, they do continuous drainage versus other sites where they place an EVD and keep it clamped to be used as an ICP monitor, and then intermittently drain CSF for ICP control. In this study, we were not able to control for variation between centers or device choice and provider management. So it makes it a little bit more generalizable because it's looking at what people actually did and how they actually use their device as they typically would. But we aren't able to control for many of the factors that do vary. And so, one of our conclusions is that the variation in practice may be a little bit more impactful than the device itself. So in this study, in contrast to a prior study from our group, we did not find a significant difference in the 6-month GOSE between patients monitored with an EVD and those monitored with an intraparenchymal monitor. And then when correcting for some other patient characteristics, the selection of monitor type may not be the most impactful thing on patient outcome. But I think that this is certainly an interesting thing to continue working at and looking at in a kind of more controlled randomized study. And then I just wanted to thank all of my mentors here, Drs. Chesna and Bono, Dr. Temkin, and Jason Barber, who did all of our statistical analysis, and then the TRACK TBI investigators.
All right, very nice, Maddie, very nice. I think, a comment to you and then open it to questions in the minute or so we have. Thank you for keeping us on time, is just the consideration of what the patient brings to the injury. And, just these thoughts of, well, maybe they're just overall sicker. And so, because this has been one of our big issues with GOSI at large is, trying to use GOSI TBI gets you better than just GOSI generic, but even GOSI TBI is going to be impacted potentially by things, just unrelated to the argument being unrelated to the direct lesions of that brain injury and potentially more related to the universality and just the complicated patients themselves. Any questions for Dr. Grail before we move on?
Patty, I just want to say great talk, great research topic. How do you use this data now in your decision making on taking care of these patients, or do you use this data at all in taking care of patients now?
I don't think that I use it. I think that it does help in the sense that not finding a significant difference gives you options as a clinician to make a more individualized decision when you're taking care of a patient. I think one of the things that we talked about that we can't control for is the decision to do a different monitor in a different patient. So I think, in some ways, if we believe that there's no difference just based on the type of device that you use, it gives you freedom as a clinician to use the device that you think is most appropriate in a patient.
Yeah, I agree with that. I think that's the conclusion. It doesn't matter, and you're safe to use either one. I thought that was the beauty of the paper. Good job, Maddie. I read your paper. It was great. Thank you.
Yeah, great work. All right. And thank you for the comments and considerations, Dr. Bono. All right. In the interest of time, we will move on. Sticking with our PGY-7s, hearing from those that are almost out the door, Dr. Sen is up next. And boy, Rajiv, you were glad for punishment. 2 fellowships headed off to New York, my friend. All right. Always something new to learn. Well, another grant-funded resident, SNIS grant, I want to acknowledge, that I'll turn it over to Dr. Sen for his presentation. It's really exciting to see you guys grow and evolve.
Yeah, it was almost 3 fellowships, so not as much of a grant as you think.
You're a slacker. Come on, kiddo. You can do better than that. Just kidding. Wonderful, though, and very exciting to see what you are off to next.
Thanks, Dr. McDonald, and thanks everyone for hanging in there. Is this coming through?
Yep.
Great.
Yep.
So today I'm going to talk about the natural history and management of residual non-functioning pituitary adenomas after endoscopic transsphenoidal resection. So to give this project some context, I think as many of us know, non-functioning pituitary adenomas are those that are not secreting any hormone and typically present when they've become large enough to compress local structures, specifically the optic apparatus, the pituitary gland and stalk. And if you look at the literature, even in the most experienced hands, the rates of subtotal resection can get as high as 20%. The natural history of, for tumors that are these non-functioning adenomas that are observed with serial imaging is pretty well documented. But what happens to the tumors after they've been resected and there's some residual is less clear, and that's what we tried to explore. And then management options for residual tumor include, obviously observation, stereotactic radiosurgery, and then repeat resection, either again transsphenoidally or transcranially. And the latter two, with radiosurgery, the rates of delayed pituitary dysfunction are pretty high, get up to about 40%. And repeat surgery is never easy, especially in this case. There's scarring, abnormal anatomy, limited options for reconstruction of the skull base. So those are things to consider when treating these patients. So our goal was to look at our extensive series of patients with non-functioning adenomas and look at what happens to tumors that were left behind, and kind of develop some basic framework for decision making and how to manage them. So we did a retrospective review. We looked at 878 patients who underwent transsphenoidal resection at our center over a 12-year period. Had to exclude a good number just due to lack of enough data in the EMR, or patients who had surgery at other hospitals, but ended up with 503 patients. We stratified them into 3 groups: those that had gross total resection, those that had subtotal resection that did not require further treatment, and then subtotal resection that did ultimately get treated one way or the other. We looked at clinical, radiographic, histopathologic characteristics of the 3 groups, and then kind of did a focused analysis of the patients who had residual tumor that ultimately underwent further treatment. Just to focus on the, given time, focus on the salient points here. Here are the radiographic characteristics of the 3 groups. We had 78 patients that were subtotally resected, so it was about 15%. And none of this is surprising. The tumor size for the patients in the subtotal resection group tended to be larger. There was a lot more cavernous sinus invasion. So if you look down on the red here, NOS classification, for those of you not familiar, is just a grading scale for how far the tumor extends lateral into the cavernous sinus around the cavernous carotid, grade 4 being encasement of the cavernous carotid. You can see, nearly half of those patients had encasement or near encasement of the cavernous carotid. And then suprasellar extension, so tumors extending now into the intracranial space. Almost all the tumors that were subtotally resected also had tumor in the intracranial space. So just kind of highlighting that these are bigger, more complex tumors that end up having residual. We then looked at these 78 patients that had underwent subtotal resection and followed them with serial imaging. So this is the Kaplan-Meier curve. On the y-axis is the risk of progression, follow-up in months on the x-axis. So you can see here the red lines delineate the 2-year, 5-year, and 8-year progression-free survival. So 2 years about 80%, at 5 years roughly about 60%, at 8 years about 10-12%. So pretty steady rate of progression of these residual tumors. By about 5 years, half of these residual tumors will show signs of progression and growth. And this figure really just highlights why it's important to follow these patients in the long term, and with fairly consistent imaging. And to drive that point home, we have the swimmer's plot here. So the way to interpret this is each line here represents a patient's trajectory over time. The lines in red are patients who had progression of their residual tumor. The lines in gray are the patients whose residual did not grow. And the dots and diamonds and boxes here, which are probably hard to see on your screen, but basically are time points at which the tumor was documented to have grown, and then when they were treated after that. And the take home from this is just to take a step back and look at it, and you can see that there's this wide range of some tumors are growing a few months after their initial resection, and some don't grow until nearly a decade later. So there's this huge range of when these tumors are growing and when they get treated again. So again, why we need to keep a close eye on them and for a long period of time. Focusing in on the patients who had subtotal resection that ended up getting treated again, just some notable features here. So the location of the residual, a lot of these tumors end up growing outside of the cella. So a lot of them have cavernous sinus involvement, again, into the intracranial space, suprasellar region, and some of them are even growing down inferiorly into the clivus. Indications for why these patients underwent treatment, most of them are asymptomatic growth of residual, but some of them did have visual symptoms, need decompression of the optic apparatus. In terms of what retreatment patients got, 7 of them got surgery, 6 of them ended up getting stereotactic radiosurgery, and then 7 were observed due to patient-related factors, preference, age, things like that. And then complications, a lot of these are kind of minor complications that were temporary. So CSF leak, transient cranial nerve palsy, all of these are to do with repeat surgery. And then one of the patients that got stereotactic radiosurgery had pituitary insufficiency. So we came up with this kind of basic flow chart to help guide how you think about managing these residual tumors. So I'll walk you through it real quick. So you have your initial resection, and then when you have residual tumor, if there's still a lot of tumor left, say you get referred a patient who underwent surgery outside hospital, if there's enough tumor left that's encroaching the optic apparatus, it's good to consider repeat surgery in the near term. If it's a small residual, you follow that with serial imaging, like we talked about, close, frequent imaging over a long period of time. And then if there's growth that's primarily within the cavernous sinus, I think those are probably the better patients that should be considered for radiosurgery, just given that you're a little bit farther away from the gland and stalk and the optic apparatus. Surgery is still possible there, but those I think are the better patients to consider radiosurgery for. When you start getting regrowth into the cella and then up towards the intracranial space, towards the optic nerves, those are probably the patients to favor surgical resection, given the ability to decompress the optic nerves, but also avoid irradiating those structures. So from the study, there are a few take-home points. In our series, we have a subtotal resection rate of about 15%, which is probably an overestimation given the number of patients we had to exclude just based on lack of data. But still, it's within kind of what's been previously published. And then close long-term follow-up is really important, not just following them for many years out, but pretty frequently, because as you can see, that some tumors grow pretty quickly, some don't, and that's probably based on the biology of these tumors and something I know Dr. Ferrer's lab is really looking into. The decision-making is not easy for these patients, and it's multifactorial, takes a lot of things into consideration. I really kind of dumbed it down there, but one of the main things to take into consideration is the anatomy and the location of the growth of tumor in terms of deciding between surgery and radiosurgery. And none of those options are without risk. So it's really important to be judicious about how you treat those patients and how you follow them. And then I think a big take home for me from this project is I think it really highlights why we are really aggressive about, taking out these tumors, even though they're benign. You see our attendings exploring the cavernous sinus, aggressively kind of, exploring the opening the diaphragm and exploring the intracranial space, because really your best chance is your first chance, and these tumors are going to grow back eventually. So especially for young patients, that's something to take into consideration. So thank you everyone for listening. Thanks Dr. Ruzovic for leading the way at this project and amassing a really strong group of med students that have put together an amazing and robust database of all the pituitary adenoma surgeries we've done over the years. So I'll take any questions.
Thank you, Dr. Sen. And I see Dr. Ramirez has his hand up. Nino.
Yeah, very cool talk. And quick question, do these non-functional tumors ever become functional when they regrowth? I mean, do you see effects on hormones or so, or is that
I anecdotally, I haven't seen that, and I don't think I've read about them becoming secretors. I think sometimes a tumor can be thought to be it can be kind of silently secreting and be considered non-functioning, and then grows and then its biology comes to light, and I guess that would be one scenario. But we are looking at we do have data on the pathology, more detailed data on the pathology of these tumors, and that's something we're looking into a little more detail and how that relates to this kind of recurrence and growth of residual. But yeah, no, I don't know if a true non-functioning tumor has ever suddenly become functioning, and I don't know if the other attendings have experience with that.
No, I think you said it right, Rajiv. Sometimes that there can be these clinically silent or whispering tumors where it's a little unclear of whether a tumor is non-functional or not. And then, like you said, its true biology comes out with time. But I just want to put in a plug for your effort and all the other residents and medical students' efforts in this. And, we're really trying to implement this large scale, very granular, prospective database for our pituitary and tumor patients. And I think work like this stems from those efforts. And there's a lot more, very basic questions that, impact our clinical decision making on a daily basis. And so just really implore for those residents that are interested in this kind of work to reach out to Dr. Ferreira and Dr. Emerson and I. And we're always happy to help mentor projects like these.
Well, thank you, Dr. Ruzovic, because yes, we are trying to send a few residents and students your way. I don't know if he was proverbial saying ears were burning last evening, but yes, a really exciting opportunity and a huge database, like you said, that you can answer a lot of questions off of. Well, thank you, Rajiv, for that excellent presentation. I think in the interest of time, we will move on to Adriel, our last speaker of the day. And just if anybody that can stay on, I know everybody's got busy schedules, we want to try to give the last speaker just as much attention as the first speaker of the morning. So I'll turn it over to Dr. Barrios Anderson to tell us about, if I remember correctly, this is a pretty rare condition, lots unknown here that can cause devastating effects in kids, if I'm remembering correctly. But we'll turn it over to Adriel to hear his presentation.
That is correct. Thanks, Dr. McDonald. I'll be efficient, everyone. The case I'm going to talk about, it's a case series that I've been working on, describing a novel surgical approach used for treating a very rare pathology called neuronal ceroid lipofuscinosis type 2. Briefly, we'll go over the background of the pathology, the reason why the intervention that Dr. Hauptmann was able to develop is useful in this patient population, and then our brief case series. To give some background, this is a rare disease. It's a form of Batten's disease called neuronal ceroid lipofuscinosis type 2. It involves a deficiency in the enzyme tripeptidyl peptidase 1, which is a protease that cleaves N-terminal peptidases from various substrates in lysosomes. And so, like many lysosomal storage diseases, it's essentially characterized by an accumulation of a large amount of protein that essentially becomes functionally not helpful and leads to widespread cell death and atrophy. In particular, its effects happen in neuronal cell bodies, which is why it leads to neuronal degeneration. And it's fatal, prior to the development of its treatment, has been a pretty fatal disease that leads to a classic clinical course where patients at the age of 2, the earliest, after normal neurologic development after birth, start to have a rapid regression in neurologic development, and the decline involves seizures, not congenital blindness, but progressive blindness that happens at a young age, as well as early death. And then again, that is because of the development of these lysosomal, the accumulation of the lipopigment in lysosomes. So, in 2017, ceroliponase alpha, a recombinant form of the TPP1 enzyme, that protease, was developed and approved by the FDA for replacement therapy, by injecting that specific recombinant enzyme into the ventricular system. It has been found to be extremely helpful in not only slowing, but even completely halting the disease for patients in terms of their progressive seizures improve, their blindness can be either reversed or halted slowly. And more importantly, the survival as a result of the direct treatment is enhanced for patients. The treatment course involves direct administration into the ventricular system using something like a Rickham reservoir, which is how it was initially described. And it involves about every 2 weeks, patients get intraventricular delivery of this enzyme because, as you know, it's a progressive disease, a lysosomal storage disease that constantly needs enzyme replacement because these patients are not actually don't have the genes to make the protein regularly. So they're systematically given the treatment on a regular basis, coming in every 2 weeks or so. The challenges for this, as you might imagine, is one related to repeated access and aseptic delivery. These are quite young patients often, and so the ability to do this regularly has sort of practical challenges in terms of doing it aseptically many, many times. Even though our clinicians can make our best efforts to do that, the chance of infection or even just shearing of the Rickham reservoir over time with this much delivery throughout the lives of these patients can lead to challenges. And they have been noted in terms of that need for high revision rates with this Rickham reservoir setup, as well as challenges with the comfort of patients, their ability to comply, especially with the discomfort of getting an injection of the medication through the scalp. And then this particular medication requires a long infusion of about 4.5 hours, which is another challenge. It's not a quick delivery, but rather something that patients need to sit through for some time. And you can imagine that can be difficult for 2 to 4-year-old patients, or really anyone that would be getting this type of extended treatment. And so Dr. Hauptmann at Children developed a novel idea of converting the delivery method to a chest power port delivery system. Essentially, the method is that you take the intraventricular catheter that's placed, connect it to a Rickham reservoir, and then tunnel it to a distal chest port site that's either fascial or epifascial, in the fascial or epifascial plane, connect it to the distal catheter, and you have an access point now, a chest power port, that is much more robust. The system itself is more regularly used for long-term infusions, and it's in a more comfortable place. And so this is an illustrative case. We have imaging showing one patient who has this particular design. And the benefits, both theoretical as well as in our limited clinical experience with this cohort, is that it is better tolerated by patients and families. We have yet, since delivering this, had infections of the chest power port or failures as a result of the system. You can see that you have our tubing going here and then going to this chest power port access site here on this postoperative shunt Rickham series. But in this limited case series, we have about 6 patients now that we've followed, 3 of whom we have data that I talk about here. You have patients from age 4 to 19 that have been accessed, many, many times since they've presented at Children's, have had no revisions of the novel system and had no associated infections. And again, the system seems to be well tolerated. And so we're describing the system in the case series primarily because you have this novel medication that has some challenges in terms of its delivery, but for this small patient population, who have tremendous benefit from this disease's novel treatment, can have a slightly more efficacious way of delivering medication with a lower risk, hopefully, of infection and failure, and that can reduce the amount of operation rates as well as troubleshooting this delivery method. The clinical experience thus far suggests the system is well tolerated by patients. Chest ports are designed for prolonged access, and they're generally a sturdier system. Even the catheter and the port access site tubing system and is thought to be more robust. It's less prone to shearing. And then this question of sterility, ease, and comfort for patients, those are things that anecdotally in our small case series seem to be the case, and certainly require a little bit more definitive work to see, particularly whether infection rates and operation rates are at all affected by this system. So the future directions, I think, for this work is first, we have a system that one can be utilized in this pathology, CLN2. However, it could be very well applied to chemotherapeutic, immunotherapeutic, and gene therapy treatment modalities that require intraventricular treatment, both in the pediatric and adult setting. The need for further characterization of the actual system in terms of how efficacious it is an important one that I think we can broaden the different pathologies that we use a system like this for in studies subsequently to really answer the question of efficacy and infection rates. I think this group of patients are certainly too small to get that type of population data, but the case series I think is useful because it is in this unique population that requires these long infusions in children that you have potential benefit. So I think that this is a very exciting project. I'm happy to have been invited by Dr. Hauptman and Dr. Goldstein, as well as mentored by Dr. Boop, who is leading the charge on this paper that we are completing soon and will be publishing shortly.
Well, excellent work. It's a tough problem. I would say my question to you and to the group is, do you think that they're in thinking forward? I was just shocked to even see a 19-year-old, like, wow, somebody with CLN2, 19, wow, that person's still alive. That's amazing. I think my question to you, Adriel, is do you think there's a role for assessing like quality of life and then elements of functional outcome? Does that also help them, hit those kind of cognitive milestone development markers better? Have you guys thought about, pulling some of the assessments or doing assessments with these participants, just given that it's such a rare population?
Mm-hmm. No, I think that would be a very good question to answer. I think whether we do it even just in a sort of qualitative a qualitative approach to get a sense of even if we can't get quality metrics that meet statistical significance or can be used in statistical studies, I think qualitative descriptions of how family members and the patients themselves tolerate the procedure, and then more importantly, the subsequent sort of treatment as a result of the system would be very helpful to know. Agreed.
Any other questions from the group as we get down or up, depending on your philosophical bend, to the hour? Any last questions for Dr. Barros Anderson? Okay, well, I think you're officially off the hot seat. Very nicely done, Adriel. It's always interesting with some of these conditions. Sometimes rare doesn't always get studied, but rare is still really important, especially major impact on patients and their families' quality of life too.